Hello and welcome to another edition of Sound Magazine, public affairs programming. Things that are important to people in Western New York. Different events, different organizations. You'll hear about them here, and if you have one and you'd like to contact us, by all means, please do so. We would love to have you on Sound Magazine with your public service organization or charitable group. We'll give you information at the end of the show on who to contact and how to get your public service organization on Sound Magazine.
Welcome to this segment of Sound Magazine. I'm your host, Tammie Lee Demler. Joining me today, Maria Cartagena, who is a physician, a medical physician and a psychiatrist. She's the Chief Medical Officer at BryLin Hospital Systems. We welcome you.
Hi, Tammie. Good morning.
It's good to have you here. I know that we were thinking, what is the optimal topic? But now that it's getting sunny and bright, I think we have a lot of things to talk about in terms of mental health and making sure that we're very healthy in terms of our brains and moving ahead. Lots of controversy, though. We're going to start with all the controversies we've heard about bed closures and mental health delivery. You're here to help us understand a little bit better about some options out there in the community.
Yes, absolutely. I think it's important to recognize that some major changes actually happened in behavioral health over the last year or so, and that those changes actually have posed a bit of a quandary for some individuals in the community in terms of what are the psychiatric services that are available out there. Now, recently, Kaleida Health, Buffalo General Hospital, had closed their inpatient units and transitioned them to a larger system, to create a larger system over at the Erie County Medical Center, who have just opened up a new facility for their CPEP, which is their Comprehensive Psychiatric Emergency Program. And then they also have a number of units and inpatient psychiatric beds. It's important for the community to know while those services exist, there are also treatment alternatives for inpatient care. And one of those alternatives is BryLin Hospital, located on Delaware Avenue in the city of Buffalo. Additionally, BryLin offers an outpatient mental health clinic as well, offering not only chemical dependency, but behavioral health, mental health services.
You were mentioning that some people might just connect BryLin with substance abuse programs, and in fact, you offer a full array.
Yes, absolutely. And I think that's probably one of the most important things to really bring to the community is the fact that BryLin actually houses inpatient psychiatric services in the city, and in addition to outpatient behavioral health, mental health treatment in their Williamsville location at Farber Lakes, in addition to their chemical dependency also located in the Farber Lakes facility in Williamsville.
How do people start kind of journeying through the maze? You know, if services are necessary, where there are coverages accepted, I mean, where can somebody start? So let's say, for example, I feel after this program I might want to see a referral specialist. Do I need a referral? Can I just come to you? How does that work?
Well, oftentimes, Tammie, people will start with their primary care physician. Primary care physicians are familiar and are being made familiar with all of our treatment options, but a patient can actually ask their their primary care physician for a referral to see a psychiatrist in the community, a therapist, a psychiatric treatment provider, such as a psychiatric nurse practitioner. And so this is available at BryLin's Farber Lakes facility, as it is available at a multitude of outpatient psychiatric treatment facilities as well. Mm-hmm. Sometimes patients feel more comfortable beginning that process seeing a therapist, and therapists are also available at the BryLin facility, as well as a variety of other places and clinics in the community as well. So that's always a good place to start. If there are concerns that the symptomatology is more severe, possibly life-threatening, if family members recognize that there may be a potential danger to an individual, then obviously we recommend an inpatient hospitalization, and that, of course, is a service that we provide at BryLin on Delaware Avenue.
And it all can really just start from a phone call. My guess is that you have excellent triage people there, and if somebody calls for, a sense of, if an appointment is needed, you can certainly help them.
Absolutely. And our switchboard number is we have a live person 24/7 answering and helping to direct traffic to what would be the most appropriate.
You mentioned too that there are some great resources in the community that would help steer a person with some peer support groups and such, and Mental Health Association is one of those.
Yes, absolutely. The Mental Health Health Association is actually able to provide up-to-date information on where the latest groups, peer-supported groups are, and they can actually help to direct traffic in terms of where might be the best facility for an individual. Of course, BryLin would be able to provide that in terms of the psychiatric piece.
Mm-hmm, for sure. We're here to talk a little bit about bipolar disorder. We had kind of ranged between topics, but a lot of people have a misunderstanding of this, or not a true, clear understanding of what that is. So tell us what is bipolar, what causes it?
Sure. Bipolar disorder, actually, it's also known as manic depressive illness. So some people know it as that. But the professional term and the current term is called bipolar disorder. It is a brain disorder, a psychiatric illness that encompasses a distinct shift in mood, a distinct shift in levels of energy, focus, and concentration. It's generally characterized by very distinct episodes of either elevated, grandiose, euphoric mood, periods where there's an increased amount of energy uncharacteristic for that individual, generally lasting more than a week. And then that distinct episode actually starts to shift into a depressed phase where there is no energy, no motivation. There can be severe feelings of hopelessness, helplessness, and sometimes very frightening thoughts of suicide, and unfortunately sometimes suicide attempts.
Mm-hmm. When we think of suicide, I think many people think of the typical classic maybe misunderstanding or myth. People give things away. They start to talk about sad thoughts. Not always is there a classic description of suicidal behavior, right? I mean, it can be different than that.
Absolutely. And so there are certain risk factors, and bipolar disorder is a risk factor. There's an increased risk of, obviously, suicide attempts with patients that suffer from depression and also bipolar disorder. And I think we sometimes forget that patients with bipolar disorder, carry that risk as well. Also, the majority of suicide attempts occur within the context of alcohol or substance abuse, and when patients who suffer from bipolar disorder do carry a high comorbid degree of substance abuse, that is, is a high percentage of patients who have bipolar disorder that also have substance abuse, and that can actually impair judgment and can lead to some unfortunate impulsive behavior.
How common is this? I mean, are we talking about 1%, 2%? I know you probably, it's hard to measure everybody, but what's your sense of that?
It's about 2.6% of the U.S. population over the age of 18 will suffer from bipolar disorder in a given year. It's a total of about 5.7 million Americans.
Mm-hmm. And with bipolar disorder, you mentioned depressed phase. Is it different because only of that manic episode, or is there a different sense of that depression?
Well, the depressive phase can look and mimic can look exactly the same as a normal major depression that people can suffer from. However, in treating bipolar depression, it can be a more severe depression causing a lot more what we call inertia. That's low energy. Patients aren't able sometimes even to get out of bed or get off of the sofa. But yes, that depressive phase actually looks very similar to what we call unipolar, just straightforward depression. The difference being that not only do you go from that depressed phase to a normal mood, but then there is also the possibility of the more elevated, euphoric, enthusiastic, exuberant mood. Mm-hmm. Unfortunately, Tammie, sometimes that mood can deteriorate into rage and rageful episodes, violence, aggression, and in some cases there can be at the same time coexistence of both depressed symptoms and manic symptoms. So in these particular cases, the clinical picture is fairly complex, and patients may be very, very difficult to manage, particularly by family members.
Mm-hmm. In your clinical experience, other than what I've mentioned, are there other myths or misconceptions that you think would be important to clear up right now?
Sure. I think a lot of people feel like bipolar disorder is when people have these normal mood swings. They go from, having a hair-trigger temper. They can go from being in a good mood to all of a sudden very angry and irritable, and it happens many times throughout the course of the day. While there is a type of bipolar phase that's called rapid cycling, most people, what they're referring to is irritability from maybe an anxiety disorder, or a depression, and not necessarily the actual bipolar disorder, because let's not forget that the bipolar disorder must, by definition, have these distinct episodes for the mania lasting about 7 days, and for the depressive phase lasting at least 2 weeks. So those are really fairly discrete periods characterized by fluctuations in the level of energy.
It sounds like it's a really difficult course, a clinical course to address and to also suffer from. I mean, does this run in families? Is this something that you would expect to be, my mom had it, my dad had it, I would get it?
Yes, there's an increased risk of inheriting this, but it doesn't mean that if you have a relative that suffers from bipolar disorder that you will absolutely suffer from that. The majority of people who do have a first-degree relative with bipolar disorder do not develop bipolar disorder, but it is, we feel, a heritable trait.
Mm-hmm. Have I, at some point in my journey through life, if I've reached a certain age, am I clear? Do I know that then no longer will I be at risk, or can it happen at any time?
Well, probably about half of the cases actually present before the age of 25. There is no cutoff. We do see that this is an illness. The median age of presentation is about 25. That means that there's half of the cases present at ages older than that, and the other half at ages younger than that. Generally, it's an illness that does get diagnosed before the age of 30. However, sometimes the diagnosis can be difficult to make, and a lot of times we do diagnose depression mistakenly because patients, when they're in that elevated or manic phase, don't generally present for treatment at that time. If they're experiencing an exuberant mood, exhilarated mood, a lot of energy, they're not necessarily thinking that's a bad thing. Unfortunately, if they do not get treatment and if that does not get controlled, they wind up switching into a depressed phase that can be very dangerous. Additionally, if we are treating an individual for depression that actually has bipolar disorder, sometimes the medications can cause an increased risk of switching to a mania or of rapid cycling.
Now, my last question for you, we only have about a minute left, but is it treatable? And if so, what kind of course am I expecting?
Absolutely, it is treatable. And really the most important thing is diagnosis, accurate diagnosis. Medication is one of the most common forms of treatment. Sometimes medications can be more quickly and effectively started and safely started within a hospitalization, generally a short hospitalization, but it can also be treated on an outpatient basis as well. And medications really are the standard of care for the treatment of this illness, along with some support and therapy.
If I am expecting some sort of hospitalization, what does that usually entail? How long will I be in a hospital?
It can depend, on average, anywhere from 4 to 7 days.
Okay. And again, BryLin is an option. Other options in the community, you mentioned a few. Where can people find a good resource to just get more information about this entirely, Dr. Cartagena?
The websites that we generally refer our patients to is the NIMH, which is the National Institutes of Mental Health, a division of the NIH, and they have some phenomenal resources online. You can Google bipolar disorder, major depression, and whenever the website, the NIMH.gov pops up, I would definitely gravitate towards that one. There are many others as well, but that one is one of our particular favorites.
Perfect. Dr. Cartagena, thank you so much for coming in and for helping us better understand this disorder. You'll come back?
Absolutely.
Thank you so much for tuning in today to Sound Magazine.
All right, thank you very much, ladies. If you need free legal advice, you're definitely going to want to stick around for our next segment of Sound Magazine. Stay tuned.